वो बोला है ना
We are live.
Okay. So good evening, friends, and welcome to this 29th episode of All India Postgraduate Teaching Program, which was an initiative from ARCOS NEEP team. This is slightly a different PG program because we covered some uncovered aspects of PG program like case presentation, journal clubs, OSCE, and some didactics on topics which are not very comprehensively available in textbook. So here we are with the 29th episode of the series, and the 8th in that is about the case presentation. Today we have two short cases. One would be presented by Dr. Anshu Khatri, who is a third year resident at RIO PGIMS Rohtak. And the second case would be presented by Dr. Neha Sharma, who is a senior DNB resident at Choitram Netrale, Indore. We are thankful to both of them, and we are more thankful to, in fact, the mentors of both these residents. The resident from RIO Rohtak has a mentor in the form of Dr. Manisha Rathi, who is a senior professor and head of the Department of Glaucoma Services at RIO PGIMS Rohtak, and Dr. Amit Porwal, who is head glaucoma services at Choitram Netrale, Indore. Thank you, Dr. Manisha and Dr. Amit, for being with us and sparing time for our students. My
Thank you.
special thanks goes to the examiners for today's short cases. Professor Dr. Tanuj Dada sir, who is a professor and head of the department at Glaucoma Services, RP Center of Ophthalmic Sciences, AIMS, New Delhi. Dr. Manavdeep Singh, who is a professor and head of the department Glaucoma Services at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital, New Delhi. And my dear friend, Professor Dr. P. Satyan, who is the director of Satyan Eye Care Hospital and at Coimbatore Glaucoma Foundation, Coimbatore. I'm really thankful to all these examiners who have spared their valuable time at this hour for our students. Now, I will be requesting Dr. Deepak Mishra, who is again a faculty from BHU Varanasi, who is also a glaucoma consultant. He will be carrying forward the further programs. Over to you, Dr. Deepak.
Thank you, sir. The first presentation which is scheduled is as Dr. Anshu will present his case, and after that we will have a discussion. Meanwhile, the examiners, if wish are help in guiding them in between this queue, they will also ask the questions. Dr. Anshu, please.
Yeah, so we have 10 minutes presentation, 10 to 12-minute presentation by the resident. The examiners can intervene them in between or whenever at this point. So cumulative time of discussion will be 18 to 20 minutes. 10 to 12 will be presentation. So if it is interrupted in between while presenting the case, that can be added upon. Welcome, Professor Manavdeep Singh, sir. And
Thank
yes,
you.
please share, Dr. Anshu. Please, let's move on.
Now, very warm good evening to everyone. Dr. Prashant Bhavan and my mentor, Dr. Manisha Rathi. Very thankful to all of you for providing this
Share
great
your screen.
opportunity to me. Thank you.
Yeah, share your screen better.
Should I start?
Please go ahead.
A 45 years old female housewife, resident of Delhi, presented with complaints of diminution of vision in her right eye since 3 years. Patient started noticing diminution of vision in her right eye 3 years back. It was intermittent. Sometimes it was more in the morning and relieved as the day progressed. It was associated with photophobia and mild redness. She also noticed a difference in appearance of both her eyes. There were no aggravating or relieving factors. She went to an ophthalmologist, and there she was given some topical eye drops and oral medications, but the symptoms did not improve. There was no history of itching, discharge, trauma, surgery, pain on eye movements, no history of diplopia, polyopia, perception of distorted images, floaters or flashes of light or colored halos. Medical history. There was no history of thyroid disorders, migraine, systemic hypertension, diabetes, cardiovascular accident, or prolonged drug intake. Treatment history. No episodes of similar complaints in the past before 3 years. He consulted an ophthalmologist where she was prescribed with eye drop bimatoprost, eye drop timolol, brimonidine for increased IOP. He was just told that she has increased IOP, so we are prescribing these eye drops. Personal history. She is vegetarian, non-smoker, and does not consume alcohol. General physical examination. The patient was conscious and well oriented to time, place, and person. Her vitals at the time of presentation were her pulse rate was 78 per minute, BP was 130 by 86 mm of Hg, her respiratory rate was 12 cycles per minute, and her temperature was 98 degree Fahrenheit. There were no signs of pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Her systemic examination was also within the normal limit. Now coming to ocular examination. Ocular examination in the right eye, her best corrected visual acuity was 6/9 with minus 1.25 diopter spherical and minus 0.5 diopter cylindrical at 90 degrees. And in the left eye, it was 6/6 with minus 1 diopter spherical with 0.75 diopter cylindrical at 100 degrees. Her head posture was within the normal limit. Her forehead was also within the normal limit. The ocular movements were full and painless in both the eyes and in all direction of the gazes. Lids and adnexa was also within the normal limit. Her right eye, uh, the conjunctiva in her right eye had mild superficial congestion, and in the left eye it was within the normal limit. Her both the corneas were within the normal limit, which included the size. The size of the both the corneas were 11 mm horizontal and 11.5 mm vertical. Uh, her both corneas had normal transparency, no epithelial defect was there, and no stromal edema, and no DM folds or capes were there. Now coming to anterior chamber, the depth of the anterior chamber in the right eye was one hairy grade 2, and in the left eye it was grade 4. The pupil in her right eye was irregular pupil. There was keratoconus and pseudopolychoria was also there, and her pupil was sluggishly reacting to light. And in the left eye, the size of the pupil was nearly 3 mm in diameter. The pupil was round, central, and well reacting to light. The iris in her right eye was light brown in color. There was iris thinning with defects at 4, 7, 8, and 10 o'clock. The defects were also transillumination positive. In the left eye, the iris was brown in color. There was no thinning or any abnormal discoloration was there. The lens in both eye was NS1 in transparency. This is the picture of the patient showing transillumination positive test. Now coming to the IUP. IUP was done by GAT at 11 a.m. And the readings were 35 mmHg, 28 mmHg in the right eye and 16 mmHg in the left eye. The CCT in the right eye was 412 micrometer in the right eye, and in the left eye it was 483 micrometer. Adjusted IOP as per Ehler's correction factor in the right eye, and the pressure became 35 mmHg in the right eye, and in the left eye it became 20 mmHg. Gonioscopy was also done, and on gonioscopy in right eye there were no angle pictures visible 360 degree, and in the left eye scleral spur was visible in all the four quadrants. On specular microscopy, cell density in the right eye was 1,548 cells per millimeter square, and in the left eye, it was 2,566 cells per millimeter square. Coefficient of variation in the right eye was 52, and in the left eye, it was 26. Hexagonal cells in the right eye were 0, and in the left eye, there were 53% of these cells were hexagonal. Pleomorphism was also present in the right eye. Now coming to the fundus examination, the right eye fundus examination, the optic disc outer part included the size of the optic disc. Firstly, it was a medium-sized optic disc, which was about 1.5 mm in diameter. It was a vertically oval disc. There was no peripapillary atrophy, no RNFL defects, no disc hemorrhages were there. The inner part of the disc included the cup disc ratio, which was nearly 0.3. The NRR was healthy. There was no notching, and the depth of the cup was medium. Vasculature and foveal reflex was also within the normal limit. Now, coming to the fundus examination of the left eye, the optic disc of the left eye outer part included the medium-sized disc, which was nearly 1.5 mm in diameter. It was also a vertically oval disc. There were no peripapillary atrophy or RNFL defects or no disc hemorrhages. Inner part of the disc, the CDR of the disc was nearly 0.4. The NRR was healthy, though in the photo it looks like a slight temporal pallor, but this is a artifact of the flash of the camera. There was no notching, and the depth of the cup in this disc also was medium. Vasculature and foveal reflex was also within the normal limit in the left eye. Then the patient's OCT was also done for RNFL thickness in the both eyes, but the RNFL thickness in both eyes was within the normal limits, as you can see in this photograph. HFA 24-2 CETA standard in both eyes was also done, which showed within the normal limit. Now, my differential diagnoses were iridocorneal endothelial syndrome, Fuchs endothelial dystrophy, posterior polymorphous dystrophy, and Axenfeld-Rieger syndrome. But after taking the full history and clinical examination, my provisional diagnosis became iridocorneal endothelial syndrome. Management. The patient was already put on 3 different classes of
Please
drugs.
wait. Please wait.
Anji, sir.
Tell us why you zeroed on to iridocorneal endothelial syndrome.
Because, sir, it was a middle-aged woman, sir, and the eye was involved only it was only single eye was involved, and the eye also had increased IOP. In other diseases like Fuchs endothelial dystrophy, posterior polymorphous dystrophy, and Axenfeld-Rieger syndrome, most of them, even the 3 of them included both the eyes, and none of and there were also iris changes were also there in iridocorneal endothelial syndrome, sir. It was a middle-aged woman, and the age of the woman was also 45 years of the 45 years.
What is the frequency of endothelial changes in the other eye? I know this syndrome per se, iridocorneal endothelial syndrome per se is unilateral disease. But
Anji, sir.
what is the incidence of the other eye getting minor changes in the endothelium?
Sir, as up to my knowledge, I think there are only 80 to 90% chances that single eye gets involved. But in few cases, 8 to 10% of the chances are there that other eye can also be involved.
Okay, generally the other eye is not involved, but minor endothelial changes are frequently seen in the other eye.
Okay.
Please go ahead.
Now, and sir, management part. The patient was already put on 3 different classes of the anti-glaucoma drugs. The corrected IOP, which was 35 mmHg in the right eye, as per Ehlert's correction factor. The patient had came for the second opinion as she was advised surgery. Then she just came to reconfirm, or kind of says she just came for second opinion. Though IOP was raised and gonioscopy showed close angle in the right eye, Undas HFA OCT didn't show any glaucomatous damage. Possible management strategy, tablet acetazolamide 250 mg 4 times a day after ruling out all the contraindication to lower IP. Or surgical management could be required in this patient. Possible surgical managements, we can go for trabeculectomy without use of antimetabolites, and the success rate of trabeculectomy without use of antimetabolites are 60% at the end of the 1 year, 50% at the end of 2 years, and 20% at the end of 5 years. We can go for trabeculectomy with use of antimetabolites, and then success rate improves to 73% at the end of 1 year, 54% at the end of 3 years, and 29% at the end of 5 years. We can also go for glaucoma drainage devices, and the success rate of the glaucoma drainage devices is noticed in few articles. I have read few articles, and then success rate depicted is 70% at the end of first year, 70 to 60%. It's a range at the end of 3 years, and 53% at the end of the 5 years. The patient was actually, we lost the patient at the follow-up.
Please wait. Would you like to use GDD in a routine manner, or you will like to do some modification with considering the endothelial cell count in this particular patient?
Sir, we would like, if we are putting, firstly, we will try with the medical therapy, sir, but there are chances that 50 to 80% chances that medical therapy could fail. Then we will proceed with the GDD or trabeculectomy, sir. If we are putting a tube, then we will see that the tube should be put in the sulcus, sir.
Okay, you put it in the sulcus. The patient is a phakic patient.
Hanji, sir.
Patient will develop cataract immediately. The moment you put in the sulcus, next day patient will have cataract.
Then, sir, we should go for trabeculectomy with use of antimetabolites, sir.
Okay, these are difficult cases, no doubt. These are difficult cases. Everything is difficult in these cases, but with such a low endothelial cell count, doing such
Hanji, sir.
advanced surgery without any, optic disc changes, and I do not know. Dr.
Sir,
Tanuj,
firstly,
can you comment?
Hanji, sir.
Anshu, you have finished or you have another slide?
No, sir, I have finished, sir.
Thank you, slide. Okay, thank you. Very good. Anshu, you presented very well, but now you will have to undergo grand viva.
Okay, sir.
First is your
Yeah.
history. You said patient has got variation in the vision in the morning and evening. Why
Thank you,
should
sir.
that occur?
Sir, it is because of the corneal edema, which is more in the morning, sir. And as the day progresses, the corneal edema settles and vision
Can
improves
you
of
do
the patient.
anything for if patient wants to patient gets up in the morning and wants early restoration of vision? So can you do anything to make his vision better in the morning?
Sir, we can use hypertonic salines at the time of the sleeping, sir. We can put one drop with soft contact lens also. Or, sir, without soft contact lens, we can put hypertonic saline.
No, there is no role of. Why would you use soft contact lens? That will worsen the corneal edema. No, that will cause hypoxia. So you can use hypertonic saline. Sometimes even you can use hair dryer.
Okay, sir.
Okay.
Yeah,
Second issue is what is the main pathology in this syndrome?
Sir, actually, the main pathology in this syndrome is abnormal proliferation and migration of the endothelial cells, sir.
So in your examination you presented, you have to
Yes, sir.
present a corneal examination. No, what was the corneal endothelial examination? On the slit lamp, you have to
Yes, sir.
mention that you did spectral reflection and what is the classical finding of this syndrome. No, so that very critical
Sir.
information you missed in your corneal examination that must be put on the slit lamp. What are the findings that point towards endothelial disease?
Tanuj,
slit lamps,
Dr. Tanuj, can I just interrupt you for a moment?
Sure.
Can you just go back to your
Yes.
slide so that we can come from the first and then we can slowly go ahead? Yeah. No, not this. Yeah, this part is fine. Just a photograph. Yeah. Please go ahead with Tanuj's questions, please.
So just go back one slide. So that is what I'm saying. Your corneal endothelial examination, you have not mentioned anything. You have just written no DM folds KPs, but relevant to this case would have been, you mentioned there is classical appearances are there, beaten metal appearance.
it is bronze beaten appearance, silver beaten appearances.
Yeah. So that is something you should mention here. Second thing is,
Sir, Hanji, sir.
Your gonioscopy, you have written nothing visible. Patient has got clear cornea, 6/9 vision. So
Hanji, sir.
what do you mean by nothing visible?
Actually, no structures were visible on gonioscopy, sir.
That is due to peripheral anterior synechiae formation, no?
Hanji, sir.
So you have to mention what is the abnormal finding. Angle
Okay,
structures are not visible because the iris is occluding the angle structures, no? So you have to mention that there is peripheral anterior synechiae and iridocorneal adhesions coming from the iris to the periphery of the cornea. So that is the main finding in this syndrome, that you have very anterior synechiae formation that causes glaucoma. So you have to clearly mention what is the characteristic in gonioscopy.
Yeah. So just trying to give you some more tips is like whenever you are already you have come to some conclusion already, and you must remember what are all the positive findings and also the negative findings, so that you can really go with your towards your diagnosis. Otherwise, it is like you said cornea is clear, like what Dr. Tanuj was saying. When you say cornea is clear in eye syndrome, already you are deviated from towards your diagnosis. And also, you should know, like when you have a clear cornea and when you are saying that you could not see anything in the angle in the gonioscopy, again, you are contradicting your own statement. So you should not do that. Whenever you are presenting about the gonioscopy, we know typically whether you are able to see all the structures or you are unable to see even the small bit slit, the angle is closed, or is it that you have a synovial closure, or somewhere there is a synechiae, the superior is clear or inferior is clear, somewhere the structures are seen. You have to see all the four quadrants. You have to really mention like what you have mentioned in your left eye. So that is how you really proceed as a student. When you are doing this in the exam, you have to go very methodical. You should not be kind of deviating. That is one thing which you must remember. And also when you are looking at the corneal thickness and you are trying to say that the IOP is higher, Tanuj bhai, I'm sorry, I think you should proceed with your way of doing things. I just wanted to interrupt in this, so please go ahead and then we'll come back to that.
Sure. And one discrepancy is that the patient is likely to have corneal edema, and you should recheck your pachymetry, because likely pachymetry of right eye should be more than the left eye in view of your
Exactly.
edema and widening.
Dr. Tanuj, may I interject? This is precisely what happened, that we rechecked the pachymetry. We did not expect this cornea to be clear and to be thinner than the other cornea, but it came out, and we tried another machine, sent her out for an
Okay.
investigation. It came out exactly the same. So actually, there being lack of corneal edema, and then after that, UBM was also done outside, which showed 360 degrees closure of the angle. So we were not able to explain this thin cornea and lack of edema in this particular
So,
patient.
do you have some clue why the cornea is thin when examination was done? There is a clue in this. Possibly because of one reason, it could have been thinner during the examination. What could be the cause? The IOP is not too high. If the IOP is like 35, then obviously we expect the corneal edema is definitely higher. But with the IOP of 28, and still you see the cornea is thinner, or I would say reasonably thinner,
Yes.
why would you have that thin cornea in this? Is it really thin, or is it because of some reason it is appearing to be
You mean
thinner?
there's scarring? Is there scarring because of which it's thinner?
Scarring or any kind of medication?
Scarring is unlikely because they say the cornea is absolutely
Yes,
clear. And
exactly.
what
Yes,
we
sir,
can
in
see
the
in the pictures also,
photos,
Yes.
it looks clear,
That's
sir.
why these pictures we put just to show that the cornea is clear. And apart from that, the medication she has been put on before she came to us is timolol, brimonidine, and bimatoprost. No CAI had been given, no carbonic anhydrase inhibitor had been given. That was the triple regime therapy she was on. So
I would also like to ask you one question. Can you go to the
Understood.
previous slide? No, yeah, this one.
Yes,
Suppose the pressure is high,
yes, sir.
what would be the correction factor? Suppose there is a pressure is high and there is corneal edema, then what kind of correction will be required in the intraocular pressure?
Sir, firstly, we have to reduce the corneal edema, then we can comment on the adjusted IOP, sir.
So in corneal edema, what do you expect to be the, what is the problem in the measurement of the IOP? Will it be higher? It will be measured higher or lower than the actual IOP? Like here,
It
you
will
are
be
correcting
measured.
and increasing it.
Yes, sir. It
Increasing
will
it
be
because
measured.
you think it's
Yes, sir.
falsely recorded low. This is the
Yes.
impression that you have. So you have increased it, corrected IOP. And what happens in corneal edema?
Sir, we have, opposite happens in the corneal edema, sir. It gets measured higher.
It's measured higher, but we don't have any nomograms for that,
Yes, sir.
right? So, okay, go ahead, please. Dr. Tanuj, please continue.
So what would be the best instrument to measure the IOP in such cases if you have a corneal edema or you're not sure what is the other factor that is important?
Sir, in case of corneal edema, the best way to measure the IOP would be tonopen, sir.
No, is there any other corneal property that impacts the IOP measurement apart from the thickness?
Sir, rigidity or
So what is that
I'm
called?
not.
So it's called corneal hysteresis. Okay. So
Yes.
that is why whatever correction factors you use, none of them is actually very accurate, because IOP depends much more on the corneal hysteresis value rather than just the thickness. So that is why none of the formulas can actually give you the exact IOP. And
Yes, sir.
one more thing, you mentioned that patient was on 3 drugs. Just go to the next slide. So this patient, why would you like to do OCT? A patient has got 0.3 cupping, NRR healthy, no notching, healthy RNFL. So what is the utility of doing a OCT?
Sir, actually, what happened that the patient got OCT from outside, and she came with all the documents that these are my documents, and I have been diagnosed with this. So, and I was, supposed to be.
Also, Anshu, would you like to look for any progression or deterioration in any of these parameters?
So what factors would you document? Supposing you have to follow up this patient
Yes, sir.
after 6 months, 1 year, what parameters you will document to see if there is any change?
Sir, I will look for the RNFL thickness, sir. Is there any change in the RNFL thickness, or sir?
Any other parameter if you are following on OCT?
Sir, GCC, sir, ganglion cell complex number, sir.
And what about clinical change? What clinical change would you expect in this patient on follow-up?
Sir, on follow-up,
if patient has
sir,
progressed,
yes, sir.
what will happen in the fundus photograph? What do you expect to see?
Sir, I'm expecting to recheck the NRR as it was on the last visit, and sir, I would mention the same NRR, or I would like to recheck NRR, RNFL thickness, and sir, CDR, sir.
What is the earliest change you are likely to occur in glaucoma on the fundus?
Sir, RNFL thickness defect, sir.
So how would that look like?
Sir, that I would check on red free filter, sir.
How would it appear?
It would appear of sir, wedge defect, sir. Black color wedge defect.
So I think we have reached half point.
Yes, sir. Yes, sir. So we will discuss later on if any more questions are there regarding
Yeah,
to
Anshu, you
that.
presented very well. Well done.
And
Even the
also
workup
it's-
of the case was also very nice and fully worked up case. Good.
Thank you, sir.
good,
Anshu,
Anshu.
you're
And
very lucky that you got to see 3 experts in glaucoma and for this patient. Thank you so much to our experts. Thank you.
Thank you.
thank you,
sir.
ma'am, and thank you, Anshu, for such a wonderful documentation and presentation of case. And I would
Thank you, sir.
like to invite next Dr. Neha for her presentation.
Just
Dr. Neha, please.
Stop share.
Anshu, stop sharing. Dr. Neha,
Hanji.
please share.
Good evening to all my respected teachers. I'm Dr. Neha Sharma. I'm final year resident from Choitram Netralaya, Indore. I'm presenting a case under the mentorship and guidance of Dr. Amit Porwal, who is head of glaucoma services at our institute. A 58-year-old male presented with complaints of blurring of vision in the right eye since 10 days, which was insidious in onset and it has gradually worsened over 10 days. It was associated with headache, eye pain, and redness. There was no history of floaters, flashes, or photophobia, and there was no history of any trauma in the past. Patient had visited for the similar complaints to a dentist with headache 4 days back before he visited us, and he got extracted 3 teeth in view of dental infection. Past history. Patient had undergone coronary artery bypass grafting 2 years back. He had underwent multiple interventions in both the eyes due to uncontrolled diabetes. First, in the right eye, he underwent laser PRP with intravitreal injection, anti-VEGFs somewhere outside in 2020, then followed by 2 injections of brolucizumab in September and in December 2022, followed by fill-in laser, PRP laser for vitreous hemorrhage, and then again 1 more injection of brolucizumab. Then in the left eye, when he presented first, he had extrafoveal traction retinal detachment, for which he underwent vitrectomy with membrane peeling with endolaser and silicone oil infusion, along with anti-VEGF injection at our institute itself, followed by after 1 year, he underwent phacoemulsification with IOL with silicone oil removal. After 1 year, he received 1 injection of brolucizumab. Medical history: patient is he's a known type 2 diabetic and hypertension since 10 years. He's on oral medication, not on insulin. His blood sugars were not controlled. On presentation, his fasting blood sugars were 140 milligram per cent and HbA1c was 9.8%. Patient was also on aspirin tablets 75 milligrams for coronary artery disease. Coming to the examination, external examination, head posture was normal, ocular posture was orthophoric, pupillary reaction on torchlight, right eye 4 mm round regular, but it was sluggishly reacting to light. A left eye 3 mm round regular, brisk reacting to light. Coming to slit lamp evaluation, right eye uncorrected visual acuity was 260, which improved. With pinhole, it improved to 560, and there was no improvement with the glasses. Lids and adnexa were normal. On conjunct, there was circumcorneal congestion present with corneal edema. Epithelial corneal edema was present in the right eye. Anterior chamber, Van Harris grading 4, and it was quiet. Iris, 360-degree neovascularization of the iris was found. Pupil, 4 mm round regular, sluggishly reacting to light. Lens, there was cataractous changes of nucleus sclerosis grade 1 to 2 with posterior subcapsular cataract. On applanation tonometry, the IOP was recorded to be 44 mm of Hg. On performing gonioscopy in that eye, there was a frank blood in all the quadrants present. There was 270 degrees, 3 quadrants, peripheral anterior synechia was present. Left eye, for the slit lamp examination, vision was 624, which improved to 618 with pinhole, and best corrected, the vision was 618, and with near correction of plus 2.75 and 24 vision. Lids and adnexa were normal, conjunctiva was normal, cornea, anterior chamber, and iris were normal. Pupillary reaction was pupil was 3 mm round regular reacting, and it was brisk reacting to light. In lens status, it was pseudophakic eye with posterior chamber IOL implanted. On applanation tonometry, pressure was found to be 17 mm of Hg. On gonioscopy, there all structures still ciliary body band was seen with a few emulsified silicon oil bubbles were present and all the quadrants could be seen. This is the gonioscopy diagram. In the temporal quadrant, till 270-degree posterior peripheral anterior synechia was present. Only temporal quadrant we could see till scleral spur, and frank blood was present in all the 4 quadrants. And in the left eye, till ciliary body band, the structures can be seen, and a few emulsified silicon oil bubbles can be seen. For the fundus evaluation on indirect ophthalmoscopy, right eye media was slight hazy because of the vitreous hemorrhage. Disc, it was normal in size and shape, but the color was palar was present. Coming to the foveal reflex, macula, dull foveal reflex was found. Blood vessels normal, AV ratio was there 2:3 with background retina 360-degree PRP laser marks could be seen. CRA patches were seen. Similarly, in the left eye, media was clear. In the disc, normal in size and shape. Ischemic pallor was present in the left eye as well. Foveal reflex dull. Blood vessels were normal. AV ratio was normal. Background retina 360-degree laser marks, CRA patches could be seen. This is the Amsler Dubois chart for the fundus for both the eyes. Investigations, since the patient had been chronically treated with the anti-VEGFs and the laser before, so we directly went with the OCT for this patient, and there was macular edema could be seen in both the eyes. So provisional diagnosis was both eye status post proliferative diabetic retinopathy with diabetic macular edema. The status post VEGF 3 injections in the right eye and 2 injections in the left eye. With the right eye neovascular glaucoma, status post PRP laser with images and cataract. And in the left eye pseudophakia with status post pars plana vitrectomy with silicone oil removed. Management. When the patient presented with the pressure of 44 mm of Hg and the gonioscopic features, immediately patient was put on injection mannitol 250 ml IV stat, along with tablet acetazolamide 250 mg 2 stats tablets were given, along with in the right eye iDROS prednisolone acetate 1% 6 times a day, and atropine 1% 2 times a day. Brimonidine with the timolol 2 times a day was started. And patient was and retina opinion was sought for this patient, and right eye in view of vitreous hemorrhage and the PDR, the patient was advised for pars plana vitrectomy with endolaser with fluid air exchange along with anti-VEGF injection. But patient denied for the surgical intervention at that moment, so aggressive fill-in PRP laser was advised, and the patient was reviewed after 5 days. Patient did not get aggressive laser done then, but he visited after 5 days. On follow-up visits, after 5 days of presentation, corneal edema was decreased. Neovascularization 360-degree, which it was present, has regressed and limited to the 2 clock hours. On gonioscopy, blood was only seen in the temporal quadrant. Rest other quadrants, it was resolved. On presentation after 5 days, pressures in the right eye were 32 mm of Hg. Patient was advised to continue the same medical management which had been prescribed before. On seeking the retina opinion, they have advised previously for the aggressive laser. Patient agreed for it that day, so we went with the patient was treated with the lasers, aggressive fill-in PRP lasers. After patient was again followed after 2 weeks. 2 weeks, the status was same in the right eye, but the pressures were not under control. Pressures had even risen with the Dimox and the 2 molecules of anti-glaucoma medications. So patient was advised for pars plana vitrectomy with endolaser, with fluid air exchange. Even after performing pars plana vitrectomy, 2 weeks following, after 2 weeks, the visual acuity in right eye was 160, which was improving to 636 parts with pinhole. Laser 360-degree well attached laser retina was present. Pressures were still 28 mm of Hg. So at this point, phacoemulsification with the IOL implantation with trabeculectomy with mitomycin C was advised under guarded visual prognosis. Thank you.
Nicely presented and nicely worked up, and a very, very difficult case indeed for everyone. But I would like to ask you a few questions.
Yes.
And the first question is, what are the indications of using mannitol? Not only in this case, any case in general, what is the indication of using mannitol?
Sir, acute angle congestive attack, acute angle closure, pressures, very high pressures above 40 mm of Hg, and
Every pressure of more than 40 millimeters of mercury requires mannitol.
No, sir. Mannitol works when there is a we have to there is shallow anterior chamber. So if you want to reduce the pressure by decreasing the vitreous volume, so there the mannitol can be given. So in those cases, mannitol is indicated with.
See the mannitol indication of mannitol is only one, and that is acute rise of intraocular pressure. In case the rise is not acute, even if the pressure is 60, 70, 80, it is not an indication for mannitol. Especially in a patient with CAD. This patient has CAD.
Yes, sir.
It is a potential danger to life. Every dose of mannitol in every case, and very especially in the patients of CAD, it can cause cardiac overload and the patient can die within 20-30 minutes. And patient go, if not die, at least go into pulmonary edema. So mannitol should be given very carefully. And what was the renal status of this patient? Because that is extremely important before you give any acetazolamide.
Yes, sir. Sir,
What was the renal status of this patient?
Sir, those
Renal function.
renal function reports,
So
records I could
you have probably not worked up as for this ophthalmic case, but we are not treating eye, we are not treating neovascular glaucoma, we are not treating diabetic retinopathy, we are treating a human being. So I think renal workup is very important.
Neha is scared to tell you. Before we give mannitol to any patient, the patient is sent for a physician fitness. So the physician examines the patient with his all medical records, and only if he gives the clearance, then we go ahead with the mannitol. Otherwise, we don't give. Neha, tell the protocol for the mannitol what we give. So
yes, sir. For all the patients which we send for mannitol injection, first we get all their ECG, their blood pressure, sugars, fasting as well as the postprandial, and their urea creat levels done. Then we send with those reports, physician evaluates, and then he gives the fitness for the mannitol injection for
But a chronic rise of intraocular pressure. This is just what I wanted to stress. You might be doing all these protocols, but something which I want to stress is that a chronic rise of IOP is not an indication for mannitol.
Okay, sir.
It is the acute rise which is an indication. So I think there are 1,000 questions which we can discuss on this patient, but I would request other examiners to please examine her. Dr. Tanuj and Dr. Satyan, please.
So Neha, first I want to congratulate you because you have taken the most difficult case. So if we have this sort of case, we will never give in the exam. It is too difficult a case for, unless you are doing fellowship retina, then it's fine. So you presented very well and very tough case for anybody to manage. Now, first thing is, patient was on follow-up. So could you have prevented this from occurring in the first place?
So wasn't follow-up prevented vitreous hemorrhage or rise in pressure? Sir, actually,
neovascular glaucoma. Why did
actually,
it occur? Patient was on follow-up with you or
yes,
some other ophthalmology? Why did it occur?
Sir, this patient was on follow-up with us. He was asked when he had the time he had presented, he had before this rise of pressure, he had vitreous hemorrhage. The vitrectomy was advised for him with endo laser at that moment, but patient did not agree for it. He went somewhere other places and he was seeking Ayurvedic medicines at that time. So when his pressure had risen and he developed headache and eye pain, and with the dent, basically he was little conscious only because of the dental pain he felt he had. For that he visited and later he came to us.
So supposing patient has come to you, he is on your follow-up. How do you know that laser has been done adequately or no? How will you assess whether laser is adequate or no?
Sir, laser adequacy of laser, sir, there is no recurrent. If vitreous hemorrhage recurrently, if it is happening, it means the laser is not adequate, sir.
No, any test you can do to
the FFA fundus fluorescence angiography we can do, so leakage is there.
You do fluorescence angiography to see if there is any ischemic area, whether patient requires additional laser. Okay.
Yes.
Now this patient is, and you have first done the vitrectomy and then you have done tabectomy combined surgery. So
Yes,
was there any other option available to you? what is the risk if you do first vitrectomy and then you, after 2 weeks you do tabeclectomy, phacotabeclectomy? What is the risk?
Sir, with vitrectomy and even with the cataract surgeries, these worsens the retinopathy, PDR, the rubeosis flares up, sir, falling in.
No, if you have done vitrectomy and after 2 weeks you do trab, what is the risk?
Dr. Tanuj has given you a clue. Just pick up that clue. He is asking for a specific thing.
You want long-term control of IOP, no?
Yes, sir.
So the IOP was like 40 plus. So what is the risk of doing vitrectomy first? When the IOP is so high, is there any risk that you can think of?
Yes, sir. When in such with such high IOPs, if we do vitrectomies, then there are chances of
What are the structures on the back of the eye?
choroidal detachments. So
So what is the other name for that?
expulsive hemorrhage.
Yeah, suprachoroidal hemorrhage or expulsive hemorrhage can happen. So can we just, if Tanuj's questions are over, I just wanted you to go back to your basic slides.
Yes,
so
sir.
that we can discuss on few basics. Can you just go back to your slides?
Yes, sir.
The examination slides, that is on the anterior chamber details.
Sixth slide, yeah.
Yes, sir.
So you have mentioned that the patient has a ciliary congestion, epithelial edema, and you have also mentioned about the NVI, which is 360 degrees. So is there any kind of a grading? If this is a case, for example, this is a neovascular glaucoma, is there a way that you can really assess 360-degree grading, or how do you really say that? NVI. Do you have a grading like a grade 1,
We
grade
have
2?
Wand's grading, sir, where the NVI is graded till the pupillary. If the NVI is present in the pupillary margin, it's grade 1. Up to collarettes, it's grade 2. If it's reaching to the angles, it's grade 3. And when it reaches scleral spur, it's grade 4, sir.
Okay, so when you have a grade 4 NVI,
yes, sir.
What are the iris pattern? How is the iris pattern? How the iris pattern will be? And there is one specific thing that you will be looking for. What is that?
Sir, when we have such florid NVI, there are formation. First, so ectropion UVA can be seen, sir, in these patients.
Yes. So if you have mentioned one finding of ectropion UVA, that is the significance of saying that you already have a grade 4 NVI.
Yes.
Right? So
Yes.
moment you see the ectropion UVA, what is the gonioscopic finding that even without putting the gonioscopy, which you can really understand?
So I think
you don't need a gonioscopy for this. When you see the ectropion UVA. Yes.
360-degree peripheral sinus.
So what is the structure which is over the iris, which goes to the angle in this? When you see the ectropion UVA, why the ectropion UVA happens in this patient?
Sir, because of the contraction of the fibrovascular tissue, it pushes
Yes.
the anterior stromal anterior stroma of the iris gets pulled. So the posterior pigment epithelium of the iris get exposed, and which is actually like looks like ectropion UVA. That is called.
Yeah. So that is one thing. So when you say the gonioscopy in this patient, is that you really did the gonioscopy, or if you have done the gonioscopy, what could have been the possible risk that you should not have done the gonioscopy in this?
Possibly.
You have a clue in this again?
Yes, sir.
What is the possible risk?
Sir, what I can think of is if NVIs are present and if we do gonioscopy. So
Okay, there is a finding in the cornea, though there is one missing finding. So if that was there, probably you should not have definitely done it. But I'm just giving you a clue. What could have been the possible contraindication that you should not have done a gonioscopy in this? So when you have a corneal edema of IOP with the 44 IOP, was a chance that if there is a bulle, okay,
yes,
when you have a bulle, you should never do a gonioscopy in this patient. So what happens when you have a bulle and when you do the gonioscopy?
so bullae will rupture and they will cause pain to the patient
Okay.
once the effect of paraganglioma.
So when you have a 44 IOP and when you have so much of a florid NVI with the 360 very active, do you really feel that the patient has just only a corneal edema, or is there a multiple bullae was also there? With so much of a ciliary congestion, again you have mentioned.
Yes,
And
sir.
I'm just looking at the blood in the angle. Is it a blood in the angle in all quadrants? Means is it really a 360-degree blood was seen, or what else was seen? Is it a blood all over 360 degrees?
Yes, sir. It was frank blood, sir.
So when you have a frank blood 360 degrees, how did you really see the PIS in that? So whatever I'm saying is just to help you out. So try to see that you don't contradict your own findings. So when you say there is something, you will not see that other one. When this is there, that is possibly not there.
Satyan sir.
Yes, yes, I
Yeah,
was
yeah.
also going to say the same thing, Amit.
Yes.
And if this is the finding, if there is a blood all round, then there has to be some hyphema also.
So that's what I want
Yes.
to comment now when Satyan sir said this. When the gonioscopy was done, there's a streak line of blood all around, and only the temporal quadrant, the scleral spot could have was visible. Rest all around, only streak blood was there, and even on indentation, there was no structure visible. And this gonioscopy was performed after mannitol was given, after 1 hour after mannitol was over.
No,
So
that's fine. That's fine, Amit. I'm just trying to help
No,
out
yeah,
the
yeah,
PG.
no, I understand, sir. It is a good
Just
thing for
trying to help
Neha.
out the PG
Yeah,
for
yeah, yeah.
their exam
Yeah.
preparations.
Yes, sir.
So the examiner will look at it is sometimes
Mhm.
you are just probably you're copying it from somewhere and then you are just presenting it. It is always better you be genuine in doing your presentations and be aware that this cannot be like that. So examiner understands you better, that your findings are clear, that you have done that, and you are saying that. That's what I'm trying to say. So once you say this, then we know that you have probably copied it from somewhere, or somebody has given you a clue to say like that. So your value will come down. So don't do that. Be genuine to your presentations and try to understand if that is there, this may be there. When that is there, this should not be there. Something like that. Okay, so
Neha,
otherwise it is a good presentation. Yeah.
Neha,
Yeah.
I have something to say in your history. Can we
Yes.
go to the previous slide, previous to this?
So in this, only in the history, I wanted to comment. This patient went
Can
for
you
a
go back to
pain.
that history slide?
Previous slide.
Yeah, go
Previous
to the
slide.
history
The
part.
last slide of history. The last
Yes,
slide
sir.
of history.
Yes, sir. I'm going, sir. I
Only
think.
thing which I was worried is the patient went to the dentist for his pain, and they took out his 3 teeth. And after that also there is no relief of pain. Then he came to us. So I was just, I mean, the radiation of the pain is there, and 3 teeth were knocked off. I don't know. So that's what I was saying, Neha, that you should be aware where all the pain of the intraocular pressure can be radiated.
So anyway, if you can't go to that slide, let's not spend time on that. I just wanted to
Yeah,
point
just go
out.
behind. Just go behind.
Sir,
Left, right arrow, just go behind.
So it's actually
This is a
hanging.
very
Stop
common
sharing.
mistake that I see in the history
Stop sharing.
at UG level, at PG level, at every level, in every medical
Start sharing.
college. This is the problem I have been seeing.
Start
People are
sharing.
writing past history. History is always past. It's history of past illness. It is not past history. So this is written in the basic books of the clinical examination in basic Hutchinson's and all. It is history of past the illness and not past history. I do not know why all over the country I am seeing this past history, whether I am wrong. Sometimes I have started feeling that I am wrong probably, because everybody is writing this. I've seen the booklets, the logbooks prepared by the professors, and again writing past history. The history is always past. I don't know. I don't understand this.
During
No, no,
MBBS,
that is
the
correct
case
only.
presentation book, what we were taught, it is mentioned history of presenting illness, history of past history of illness.
Yeah.
It's
It's
mentioned in the
history of
textbook
past
like
illness,
that
it's not
during
past
MBBS.
history. And another question which I want to know, Neha, what is the difference between ranibizumab and the brolucizumab? Why did you use the other drug later on? And initially ranibizumab was used. So what is the difference in the effect of these two drugs?
Sir, first of all, this patient had already been given ranibizumab outside when he had come to us once, and his edema has not resolved. So our retina consultant, they wanted to shift to the either aflibercept or brolucizumab, which are more potent if the ranibizumab does not work. Next is the difference between ranibizumab and the brolucizumab is the size of the brolucizumab is very small, so large amount of molecules can be accumulated in the same amount in the volume which we give.
From my side, a last question, and then I think Dr. Tanuj can wind up the thing. And what percentage of cases of neovascular iris they go into progress to neovascular glaucoma? So, and what are the risk factors for this progression?
Around in diabetic patients, sir, following vitrectomy, around 18. I'm little doubtful, sir, but I think 18 to 26% of the patients, 18 to 40% of the patients, they go for neovascular glaucoma and diabetic proliferative diabetic retinopathies.
No, that's not my question. My question is, if a patient develops NVI, what are the chances? How much are the chances that the patient in due course will develop NVG?
Sir, I think 18 to 20%, sir. I'm not very sure.
Okay, Dr. Tanuj, please go ahead.
Stop sharing, Neha.
So, Neha, one last question for you. Any alternative way of management? Could you have done it in one sitting? Is there option of you did in two stages? First vitrectomy, and then you did phaco trap.
Yes,
So,
sir.
any option of doing in single stage?
In single stage, sir, endocyclo, I'm not sure, sir. Drainage devices can be done, but one sitting.
So in your Viva, you have to give options because it's
Yes.
an inflamed eye and already you have done vitrectomy. So it's very high risk that trap will fail. So
Glaucoma drainage devices.
yeah, that is option. Other is when you can do phaco with the VR, combined phaco VR, and do that laser of the ciliary body during that, so that you get short-term control of IOP. Okay, and then later on you follow it up with a proper procedure. If eye is totally quiet, then you do trap mitomycin. If eye is inflamed, then you can do a glaucoma drainage device. So those are surgical options available. It's a very difficult case. So surgeon has to have 2-3 options, what is best for the patient. And you must have the glycemic control before you do in these surgeries, because HbA1c was very high. Patient's glycemic control was not good. So in such a patient, very high risk that he may land up in other problems. So that should be systemically well controlled before you take in him for a VR surgery. Thank you very much. You presented excellent presentation.
Thank you, sir.
And well mentors.
Yeah, thank you, Dr. Neha,
Wonderful.
for your wonderful presentation. And I would like to congratulate again Amit for giving a good support for her.
And
yes,
the
sir.
physicians also, very, very difficult case indeed, actually. Very, very difficult case to manage.
But I am only
Very
still
true.
worried. Tanuj sir, do you think this patient had an ocular pain and his dental extraction was done? I mean, I still look at this patient, and because of that, he's scared now. He comes for regular follow-up. But that's what I wanted. I told our PGs also that every ocular pain, it is confined to the eye. We have to make sure whether it gets radiated, and we should know the cause of that. Today, that patient had IOP raised. That's why he had the pain. But he went to a dentist, and he got stuck there.
Dentist looks very radical. I mean, nowadays treat 3 tooth extraction at one go. I mean, it is quite radical.
Very radical.
You should have done some root canal or something. So
Usually, Amit, the referred pain usually doesn't radiate down. Usually it goes up rather than down. So possibly the patient might have had definitely the dental problem as well. Possible to have a dental problem in isolation, but the radiating pain usually comes from bottom to up.
Okay.
Yes, very true, sir. So
Thank you.
Thank
Thank you
you.
all for your wonderful
Thank you.
presentations.
Thank you, Dr.
Possibly
Ansu, and
each case we could have discussed for hours, but with a short time and so much of information, it is well done.
So can we have your video, please?
Satyan, video.
hello.
It's been a long time we saw your face. Yeah.
No, I am in a temple.
Sir
I
is
am in a
in-
temple actually.
Oh,
Okay.
good.
Ayodhya
Ayodhya or
temple.
somewhere else? You are in
Right.
Ayodhya or somewhere else?
I'm inside a temple actually.
Inside the
Okay,
temple.
sir. Okay,
Okay,
sir.
sir.
Okay,
Yeah,
It's
Thank you all for
Sure. Thank you.
Okay.
Thank you, Dr. Ansu and Dr. Neha, for the wonderful presentation, and their mentors, Professor Manisha ma'am and Dr. Amit, to guiding them to such a level they can face the stalwarts of the glaucoma. Professor Tanuj Dada sir, Professor Manadeep sir, and Satyan sir. On the behalf of whole EIS CRC team, I would again thank you all for making this CME wonderful, and hope that we will have next one very soon on the next Thursday. Till that, goodbye and thank you, everyone.
Thank you
Thank you
to
so much.
Prasant as well. Thank you to Prasant
Okay.
as well.
Thank you.
Yes,
Thank you, everyone. Thank you,
Both
everyone.
Anshu and Neha, both of you did very good. Keep
Yeah.
it up and all
Wonderful,
the best for the
wonderful.
future.
Thank you, Dr. Anshu, Dr. Neha, Dr. Tanush, Dr. Satyan, and Dr. Manadeep, and Dr. Deepak Mishra. Last but
Thank
not
you,
least.
ma'am. Thanks.
Thank you so much. But I just want to ask one question. This patient lands up with us from somewhere else on 3 drugs with no carbonic anhydrase inhibitor, which was recommended. And she has a raised pressure and somehow a thin cornea, and she has a closed angle. So what would you advise in such a patient? I actually,
I'm still waiting
What
for
I
Dr.
had a
Satyan sir's answer,
strategy.
which he mentioned in cornea. What can be the
Yeah,
clue?
yeah.
I have also trying to
Yeah.
figure out what he was.
Yeah.
No, that is the hypertonic saline. Yeah,
Hypertonics.
Hypertonic saline.
it's a very simple answer to that. It's nothing big in that.
See, but she was not using any hypertonic saline.
No,
She
that
was
is that.
using
Yeah.
Bimatopros, brimonidine, and timolol.
Okay.
In fact, people told me that for this presentation, just reverse the CCT. Otherwise, they'll ask, why was this cornea thinner? But I said we have to be true to whatever we saw.
No, never
Yeah,
do
no,
that.
no, it's
Never,
good.
never do
Never.
that. Yes.
And one
Yeah,
more
yeah.
thing I wanted to ask, because Professor MDS sir also is there, he's also an examiner in various exams. Deepak is there, Satyan sir is there. Should we mention the IOP correction formulas in the presentation? This is not,
Yeah, that's another
nothing to
issue.
comment against
Yes.
Deepak, but this is for the PGs who are watching the whole webinar. I mean, we should talk about the correction factors.
See, Amit, for the secondary glaucomas, we really don't mention this. For primary glaucomas, where it is very useful is only in glaucoma suspects and ocular hypertensives. When it is a patient who has an established glaucoma, the correction factors are not very useful. Only those suspects and ocular hypertensives, it is very useful for you to take a call on whether this patient falls into the POAG or into the ocular hypertension or whatever, or like basically the early POAG. So that
But
is
we
where it
talk
is
about
very
thin
useful.
and thick cornea only. I mean, we don't measure correction factors.
The only thing is what we need to understand is when the corneas are thicker, the progression of these patients are probably slow. It doesn't
Yes.
mean that it is zero. When the corneas are thinner, the progression of these patients are probably much higher than those with a normal or the higher